Ethical dilemmas are common within healthcare organizations and usually involve members of the healthcare team, such as patients or family members, regarding an event or decision determination. After the dilemma passes, it can lead to productive debates or pros and cons of all potential options. Moral distress occurs when individuals know or think they know the ethically appropriate action to make, but are constrained from making that action. It reflects deeper problems about a unit practice or systemic issues as a whole. It is not healthy or productive. Therefore, all levels of the organization should remain vigilant in recognizing this. Early and immediate action to manage strategies can make a big difference in the workplace. We already discussed what moral distress is. What is the reason for moral distress can be factors such as fear of legal action, restrictive policies, or issues with hierarchy. Here's what it is not. It is not compassion fatigue, which is the inability to provide care in a crisis because of repeated exposure to that crisis. It is not burnout, which is emotional or physical exhaustion due to prolonged stress. It is not psychological distress, which is physical and emotional symptoms that arise in stressful circumstances. Do you see the difference? Here's why distress is so important. Because the moral component so profoundly affects one's moral integrity and view of the profession and can lead to burnout. It manifests in 3 levels: patient and family, the 2nd level, unit and team, and the 3rd level, organization and system. The recurrence of moral distress problems can give rise to crescendo effect. What is crescendo effect? It is the model of describing the interaction over time between an increase in moral distress in repeated situations and an increase in moral residue that lingers in the aftermath. Crescendo effect may occur from top to bottom, such as executive management to middle management, or bottom to top, such as patient to provider, or between members, such as nurse to doctor. As the situation unfolds, it may increase or crescendo. Once the situation resolves, it does not go away. A residual amount of distress remains. This is moral residue. Moral residue is the feeling that lingers after moral distress. Frustration, anger, and hurt are quickly recalled. Moral residue can lead to numbness or burnout, leaving the profession. It is important for management to know the difference between those terms: crescendo effect, moral distress, and moral residue.
Emotional strain has become a component of today's healthcare organization. Various circumstances on a daily basis can lead to emotions which include anger, anxiety, frustration, relief, and sadness. Compromised moral integrity consists of feelings of guilt, powerlessness, self-blame, and decreased self-worth. Many providers do not face a dilemma with patients who experience sadness or suffering, as patient deaths are not even an issue. However, there's emotional toll experienced from not being heard, being unable to advocate for the vulnerable in community can remain in their life for extended periods of time, for months, years, and even decades. Epstein-Hamrick outlined 3 outcomes of moral distress: becoming accustomed to the moral elements of problematic cases, conscientious objection of refusing to perform a legal responsibility due to personal health beliefs, and burnout resulting leaving the profession. A study by Hamrick, Brochures, and Epstein showed that 11% of ICU physicians and 20% of nurse participants indicated leaving their position due to moral distress. Moral distress does not have one universal term accepted within management literature. Various leaders and researchers have identified it as ethical challenges in practice, organizational objection and ethics, and clash of personal and organizational values, conflicts in priority setting, and resource allocation. Min, Peacock, and Storrs describe 2 key instances in which healthcare managers experience moral distress. The first example is managers who must attempt to sell a decision or direction that they do not agree with. The second is managers who cancel their previous commitment to their staff or coworkers. Additional examples of moral distress include the manner in which resources are distributed, the decisions that powerful individuals make which are unethical, and differences between one's personal and institutional values. The Sarbanes-Oxley Act of 2002 law is intended to place more emphasis on corporations being more responsible and complying with the greater focus of ethics at management and governance level. These actions were meant to promote a healthy workplace environment. A 62-year-old individual suffers complication during surgery which led to transfer to MICU where patient displayed signs of neurological damage. Patient was transferred to a long-term rehab facility and suffered recurring strokes. With each stroke, the patient had to be hospitalized and patient lost kidney function and vascular integrity. The rehab facility team displayed moral distress as its equity increased with less chance of being able to be discharged home. Administrator understood staff concerns but also knew the consequences of negative publicity for the facility and the hospital reimbursement for extended stays. As a result, 2 nurses and respiratory therapists resigned from rehab facility.
Strategies to address moral distress. How do we deal with moral distress? Repeated moral distress and moral residue resulted in disempowerment that lead to nurses quitting their job and even the profession. As an organization leader, in order to maintain the workforce, we have to find strategies to deal with moral distress and moral residue. There are several ways to address moral distress as experienced by nurses. One of the strategies in addressing moral distress is the patient and unit level. There are evidence-based interventions focusing on nurses. One method created to manage moral distress is the 4 A's to rise above moral distress. This is developed by the American Association of Critical Care Nurses. The 4 A's are ask, affirm, assess, and action. Ask the root cause of the distress. Affirm your moral distress and allow for a root cause analysis and discussion. Assess the individuals involved and evaluate. Action. You have to take action to alleviate moral distress. Nurses encouraged to speak up about the issues. There should be an open dialogue and a team discussions. And their disciplinary education program should be considered. For patient situation, it is often characterized by poor communication and lack of clear-cut patient treatment. Emphasis on the early and ongoing discussions among team members, patient, and their families about the goal of treatment. A nurse manager who is confronting with nursing staff turnover suggested strategies for unit-level leaders. Her sensible solution included: know your staff, be familiar with what you have and who you will be dealing with. Educate your staff. Information and knowledge is the key. Challenge the culture. Accept intercultural and individuality. Use resources. Be resourceful and appreciate what you have. Match staffing to the requirement of the patient condition using objective data. Appropriate tasking and assignment to your nurses. Thank you.
System-level strategies to addressing moral distress will be unique to each institution, but there are several common actions that organizations can take to tailor to their needs. One way is to utilize the organization's mission statement to guide intervention. For example, if a hospital's mission statement involves teaching as their primary focus, the strategy to address moral distress will be different in comparison to another hospital whose mission statement involves efficient, highly skilled patient care. We can compare Memorial Hermann Health System's mission statement, which quotes, "Nonprofit, community-owned health system dedicated to improving health," against UTMB Health's mission statement of "improving health for the people of Texas and around the world by offering innovative education and training, pursuing cutting-edge research, and providing the highest quality patient care." We can see that each institution's mission is different, so the way moral distress is addressed will vary. By tailoring interventions, organizations will likely be more successful in creating a culture that responds purposefully to moral distress. Lastly, ethics consultation services. ECS is more than just an ethics committee. It is a model in which the clinical ethics mechanism is provided by an individual or a small group of experts as a consulting service. A couple national organizations that have addressed moral distress include the American Association of Critical Care Nurses and the U.S. Department of Veterans Affairs. The AACCN developed a set of strategies that decrease moral distress and promote a healthy work environment. One strategy involves developing systematic processes that includes reviewing and analyzing the system issues that enable situations that cause moral distress to occur and taking corrective action. Support systems are also in place for employee assistance, protocols for advanced care planning, ethics committees, stress debriefings, grief counseling, as well as ethicist services. The U.S. Department of Veteran Affairs also developed a way to address moral distress by implementing the Integrative Ethics Initiative. This is a system-wide ethics program based on quality improvement principles and strategies for organizational change. Three components of Integrated Ethics Initiative include ethics consultation, preventive ethics, and ethical leadership. Preventive ethics involves a quality improvement system that focuses on recurrent ethical problems at a unit or system level and only addresses moral distress. Ethical leadership focuses on helping leaders create a responsive ethical environment.